Hi, my name is Shaji Kumar. I'm a hematologist at Mayo Clinic in Rochester, Minnesota. This year's ASH meeting in New Orleans was quite exciting for the field of multiple myeloma and related plasma cell disorders. We had fantastic data that was being presented, um, it- again gathering we had fantastic data that was being presented that went into various aspects of the disease, particularly the disease biology and the precursor stages of multiple myeloma, including smoldering myeloma and monoclonic myopathy of undetermined significance. There were several biology-related abstracts that looked at the events that lead to disease progression from precursor phase to active myeloma, specifically looking at the role of tumor microenvironment as well as single cell approaches to understand the changes that happens in the clonal plasma cells. There were results from two phase 2 studies looking at the concept of early intervention with intense treatments in patients with high-risk smoldering myeloma, the ASCENT trial and the CSAT trial, both demonstrating that the combination of carfilzomib, lenalidomide, dexamethasone, and daratumumab, or carfilzomib, lenalidomide, dexamethasone with transplant can lead to deep and durable MRD negativity in patients with high-risk smoldering myeloma. Whether this will translate into long-term survival difference, especially for patients with high-risk myeloma, and whether these kind of approaches can cure a fraction of these patients remains unknown, and we will have to wait for longer-term data. There were several clinical trials that looked at the role of intense therapies for patients with high-risk multiple myeloma. And there were also data presented looking at risk stratification approaches in this disease. And it's very clear from these studies that we are increasingly starting to look at multiple myeloma not as one single disease, but rather a heterogeneous group of disorders with varying outcomes. From that standpoint, people with cytogenetically high-risk multiple myeloma is likely to need treatment approaches that are going to be slightly different than what we do for standard risk myeloma. On that theme, there was data presented from the memorial that looked at the comparison of carfilzomib, lenalidomide, dexamethasone versus bortezomib, lenalidomide, dexamethasone, and the utility of transplant in high-risk patient population, and demonstrating that carfilzomib is probably better than bortezomib in that combination for high-risk disease, and also demonstrating the role of positive role of autologous stem cell transplant for these high-risk patients. Also quite interesting was the data from both the UK trial, the Optimum study looking at 5-drug induction therapy, 4-drug consolidation, and prolonged 2-drug maintenance in high-risk patient population, and demonstrating that the outcomes of this group of patients was better than what had been anticipated based on prior studies. We also saw data from the concept trial looking at the combination of isatuximab, lenalidomide, carfilzomib, and dexamethasone, or ISA-KRD in patients with high-risk disease, and again, patients who are transplant eligible and ineligible being included in that study. Again, a single-arm study, but the outcomes, particularly with respect to the MRD negativity, appears to be quite promising, and hopefully we will have long-term data later on. In the transplant ineligible patient population, there were several pieces of important data that was presented. There was long-term follow-up of the MAIA study that continues to demonstrate an improvement in progression-free survival and overall survival for patients with newly diagnosed myeloma who are not eligible for an autologous stem cell transplant. The median PFS for this group appears to be well over 5 years. We also saw data looking at the role of autologous stem cell transplant, however, using a reduced intensity conditioning with melphalan 140 milligram per meter square in patients 60 to 75, that demonstrated no significant benefit for transplant in the older patient population. Certainly, the caveats include the reduced dose intensity conditioning, as well as the fact that a third of the patients actually did not end up getting transplant as was randomized. We also saw data from a French trial that looked at the combination of daratumumab and lenalidomide, comparing it to lenalidomide dexamethasone in an attempt to reduce the intensity and duration of steroid therapy, which demonstrated that there was an improvement in response rate and also some of the survival and with survival outcomes still elevated. So certainly this trial leads the way in terms of trying to reduce the side effects associated with steroids, particularly in the older, frail population. Now, there was a lot of exciting data presented in the setting of relapse disease with new agents, particularly the bispecific antibodies, both targeting BCMA like elranatamab and ABBV-383, as well as data from bispecifics targeting different antigens like GPRC5D. The data with talquetamab was quite comparable to what we have seen with other bispecifics. Certainly some unique side effects related to the target that talquetamab is going after. We also saw some interesting data with modakafusp, which is a anti-CD38 monoclonal antibody with attenuated interferon that appears to be quite effective in relapsed refractory myeloma patients, even after other currently available agents. There was also some interesting data looking at the role of dual-targeted CAR-T in early lines in high-risk patient population, where these patients would get that after induction therapy. We only have response data, which was 100% response, including MRD negativity. And hopefully with longer term follow-up, we'll get a better sense whether this is the approach we need to take. So overall, I think the ASH was quite exciting with a lot of very interesting data, which all will contribute positively to how we manage patients with this disease.